look at what to look for in the examination, okay, and to find out what is the cause. Now what should my be cause? Is it a nutritional cause? Is it endocrine cause? That's my third step. Okay, first step was, is the child short? We already know the child is short, less than third step. Second is, he's short for the family. So I know if he's within the MPH, his family is short stature. If it's below the MPH, it could be any of these causes which we discussed. Now how do we come to know? We are going to now know to measure some additional measurements we should do. If you know, it is good. If you don't know, but it's an ask this station, so you should know. That means I should calculate what is the height age, what is the weight age. Why should I know that? I want to know whether the the child is short and fat, or he is short and thin. So if he is short and fat, endocrine cause. If he is short and thin, yes, chronic systemic illness or malnutrition or nutritional cause. Is that clear? So that's why I want to know what is his height, age and weight age. Now how do I know that? Now in this child only, for example, how do I calculate the height, age and weight age? He is 9 years, right? So you take 9 years and when he is at 9, so you are going to plot in what is his weight. Okay, let's come to height age, 110 centimeters. At 110, you see where it touches the 50th centile. It touches the 50th centile at 5 years. Okay, so from height age, if you want to know, you just plot his height. His height is 110. Okay, this is 110. You cross it, see where it touches the 50th centile and drop down. That becomes your height age. Okay, understood? Whatever is the height, from there you draw a parallel mark, come to where it touches the 50th line. Here the 50th line is here, 50th centile. It touches at 5 years. So what is his age? 5 years. Height age. Okay. Now let's come to weight age. What is his weight? 18 or 20 or 25? 20.6. Okay, 20. So if we have is 20 kgs. So I am seeing where the 20 kgs will touch the 50th centile. Okay. So it touches at 6.5 years or so 20 kgs touches 50th centile probably at 6.5 years. So I drop it down here. Okay. This is the weight. You move to till it crosses the 50th centile and you drop a perpendicular. That becomes height, weight age. So which is more affected, height age or weight age? Height age is more affected. He is 9 years, but his height age is just 5 years. Whereas his weight age is 6.5. So height age is more affected than weight age. That means he is short and he is thin, or you can say short and but the weight age is not that affected. So therefore more likely is endocrine cause. Okay, but if his height age and weight age is affected, but his weight age is more than height age, then you think of nutritional cause. Weight is more affected. Weight age is more or less. Suppose his weight was more or less, weight age was 5 years and height age was 6.5 years. Then what I would have thought of? Nutritional cause. Correct? Here the height age is more affected. Weight is not that much affected. So I should think of endocrine cause. But if the weight age is more affected than the height age, you should think of nutritional or systemic cause. Is that clear? So this is all what is required in your short stature case for with regards to measurements. And then you should add a little bit on a few things which we will be asking you is what are the clinical features you are going to look for. Now you said so many causes, no? So many causes you should actually look for in the examination. Correct? So what will be the findings in anthropometry? What are the 3 things you should tell? You should plot the growth, you should tell the MPH, you should find out the mother site and father site and MPH. Okay, and then you should have the height age and weight age. Clear? And then 4th step will be to find out any clinical features are there of that particular disorder. Now for example, hypothyroidism. So what should I have in that baby? Yeah, it can have hoarseness, he should have dry skin, then I should have constipation. That's symptom wise. History wise, by looking at the child, he should be dull looking and then he should be dry skin. Then if bradycardia can be there, delayed relaxation of the ankle jerk can be there in a child with hypothyroidism. Cushing syndrome, so moon phases, buffalo horn, striate, you can have striate. Blood pressure can also be more. Understood? Yeah. So striate is most important. And buffalo hump and push moon faces. Clear? So that's what I'm going to look for in the examination. Suppose if I am having a child with growth hormone deficiency, I am going to think of mid-facial hypoplasia. Okay? Doll-like faces. Midline defects. You can have a central incisor, you can have a cardiac defect, you can have micropins. Okay, that's what happened in your child. So can you just go through the examination part?
General appearance. Punama's skin appears to be very alert, interested in the surroundings. No pallor, icterus, sinuses, clubbing, edema, and significant lymphadenopathy. Vital signs: heart rate is 98 per minute, regular in rhythm, normal in volume, no specific character, no radiofrequency delay, felt in all peripheral palpable vessels.
So mention all those quickly, very quickly, fast, because it's a short case now, so we should just write the most important things.
Anthropometry, weight 20.6 kgs, expected is 25.5 kgs.
Okay, so that we have already finished. Next, you should going to put the growth chart. Next, systemic exam, general examination, findings.
Head to toe.
Head to toe.
No microcephaly, face round.
So why microcephaly is important? Yeah, infiltrated infection, IUGR babies, correct. Yeah, and syndrome, like Turner syndrome or Down syndrome. That's why head circumference is important. Okay.
Face rounded and chubby. No midline defects. Eyes, nose, ears normal. Fundus normal.
Midline defects you will get in growth hormone deficiency. Okay. Next.
Oral cavity normal. No cleft palate. Dentition normal. No webbing of neck.
Delayed dentition you will get it in vitamin D deficiency. That's why they ask you rickets. You are going to get delayed dentition. Yes.
Shape of chest normal. No stature anomalies.
Okay. So vitamin D deficiency again you can get skeletal. I told you. So rickets is an example of disproportionate short stature. So you should be asking some questions related to rickets also. Okay. Next.
No webbing of neck.
Webbing of neck happens in Turner's.
Shape of chest is normal. No stature anomalies. No peripheral.
Skeletal anomalies for, I told you, mucopolysaccharidosis may cause skeletal dysplasia when you have a short term. Okay. Next.
No peripheral scoliosis.
Okay. All that is for skeletal dysplasia. Next.
Truncal obesity is present.
Okay. Truncal obesity mainly for Cushing's and also your disc pulse, whichever you told.
Hands and feet are normal. Skin down here, cutaneous markers. Hair and nail is normal. No asymmetry in the body. External genitalia, SM1 stage 1, pre-adolescent. Penis 2.5 cm in length.
So there is some microprint. Of course, you won't get this case in the exam, but I am just telling you what you should be looking, because the questions will be asked. The moment you present so much itself, they'll start asking you questions. So these are the questions they're going to ask. So what are the common causes and what history will you ask in HOPA for that? Did you understand? So for that you should have a background knowledge of causes. Now can you just tell them, because they came late, can you just repeat how do we class? First definition, we'll just complete, and then we'll just try to look at how to measure the different anthropometry parameters. We'll discuss about growth chart and then go to obesity. Yes, now can you just tell them this is revision, because they came late on what did we discuss from the beginning.
Growth and definition of the gap.
So net increase in
Size.
Okay. Next.
Development is greater.
This maturation of seeds. Okay. Next. Then we looked at short stature. Yeah, short stature only you take. No,
short stature. Classification, disproportionate and proportionate.
Yeah, first definition. Anything, first you write out the definition. Okay, short stature, three definitions.
Less than
height is less than third percentile, or -2 standard deviations, or height velocity is less than 25th percentile. This much is the definition. Okay. Next, classification. In classification, physiological pathology one way. I told you to remember it as proportionate and disproportionate. Okay. So in disproportionate I started first. What do you mean by disproportionate?
Upper segment.
Yeah, upper segment, lower segment. If it is normally it should be equal to each other, then I know that it is proportionate short stature. And that disproportion you get by knowing the different ages. There are different ratio. So at birth it's 1.7:1. At 3 years 1.5:1. At 5 years 1.3:1. And after 7 to 8 years 1:1. Okay. Suppose sometimes some ratios are altered. he can be either short trunk or short limb. Short limb example is ROACH. Rickets. O is for osteogenesis imperfecta, A is for achondroplasia, C is for chondroplasia dysplasia, H is for hypothyroidism. Clear? So whereas short trunk examples, mucopolysaccharidosis, mucolipidosis, Carey spine, TB spine, and spondyloepiphysis. If you can remember, you will know. So remember, disproportionate fit, he can be short trunk or he can be short limb. Short limb, so many causes I told you. Short trunk also, because this is an ultra short limb, 3-mark question. So you should by heart that. Okay. Then comes to proportion structure. In proportion structure, what did I tell?
Growth velocity.
Say, look at the growth velocity is normal. If it is pathological, normal variance. Normal variance to, what is the important feature of them? Growth velocity is normal. And what are the two examples? Familial short stature and constitutional short stature and delay. Okay, I told you 4 differences between them. One is height age is reduced. You tell that the height is decreased for the age and sex, but is not normal for the family. Here it is decreased, but he achieves his adult height. Second question, second difference, family history. There, no family history, but history of delayed puberty. Last difference, bone age. Bone age is normal in familial, bone age delayed. And in familial short, what's the important point? It's within the mid-parental height. Okay, whereas here it's below the mid-parental height. Okay, so these 4 differences, ultra short note, you should be knowing. Okay, and then next we came to the pathological causes. In pathological causes, we had intrauterine causes and these things, growth velocity is definitely not normal. Okay, so we found intrauterine causes. It could be infections, IUGR syndrome. Okay, and classic syndromes are Down syndrome and Turner's. Okay, so your Down syndrome child also can be kept as short stature. Okay, then acquired cause are nutritional system. Clear? So, and you know how to write, what questions to ask in the history, then what to look for in the examination, and 3 steps. Plot on the growth chart, find out whether it's less than 3rd percentile. Second step, calculate the mid-parental height and mid-parental range, and see whether he comes in mid-parental. If he comes in mid-parental range, it is familial short stature. If he comes below that, it is pathological short stature. You have to do evaluation. Okay, and then you calculate the height age and weightage. If the height age is more affected than weightage, it is endocrine. If the weightage is more affected, it's nutritional or systemic cause. Clear? And we also clear. Now next thing for theory. For theory, you should know what investigation should I do, how to evaluate a case of short stature. So what investigations you will do? So you have first tier investigation, second tier and third tier investigation. So first tier is baseline. So baseline, what you will do, you know anemia can cause, it's a chronic systemic illness. Hematology, so I told you all systems, CNS I told you CP, okay, and intracranial problems. RS, cystic fibrosis, asthma. Per abdomen, malabsorption, celiac disease, very good. Endocrine, 4 causes. Okay, then I have told you about anemia, hematology cause, anemia. Okay, so this is how you are going to write the investigation. So first line, baseline, CBC you are going to do. You are going to do, even renal failure is a chronic system. Renal failure can also cause short stature. So you are going to do creatinine. Liver disease, can it cause chronic liver disease? Can cause short stature? Yes. So you are going to do LFT. Okay, so that's why we will write the first line investigation. Okay, you may do an ABG also at that point. Otherwise, you just for renal tubular acidosis. So this is your first line investigation. Second type investigation is when you think of some specific cause, you have some features of hypothyroidism, you have features of this. So then you're going to say thyroid profile. Okay, then you're going to say suppose I have rickets, calcium phosphatase, alkaline phosphatase. Okay, suppose I'm having some specific investigation, I'm going to do that. Okay, suppose the second line also, suppose cystic fibrosis, I'm going to do mutational test or sweat chloride test. Okay, suppose I'm doing malabsorption, I'm thinking of malabsorption, so I'm going to do stool test. I'm also going to do, suppose celiac disease, I'm going to do what? No? Celiac disease, what we do? You have antibodies, no? Antibodies against. What will you do in celiac disease? So one is of course biopsy is one, but before that you can do a antibody. Antibody to what? that's your homework to write down what are the events. So you're going, that one table is given in guide, so you should write that. Why I'm spending more time in short stages? Because this is your 10-mark question also. You can have a 10-mark question, you can have a short question, or you can have an ultra short question. So that's why you prepare it in a way. If you prepare it as 10-mark question, you can answer everything. So this is what you're going to do. I'm just making you remember. So first line, baseline, all the system baseline, creatinine, LFT, CBC, baseline. Second line, specific disorder, thyroid, celiac disease, malabsorption, what you want to do, specific. Final, third line will be endocrine further evaluation. For example, growth hormone. Okay. For example, insulin like growth factor you want to do. Those are the extra tests which I want to do for third line, like last if you want to diagnose that. Is that clear? So this is how we are going to investigate the child. And after what will be the treatment? So if it's nutritional or thing, you have to take care of nutrition. If it is endocrine, thyroid, thyroxine. If it is malabsorption, think of avoiding certain things. Celiac disease, avoid meat. Correct? And if it is not, so you're going to avoid that specific disorder, you write the specific treatment. Okay? And because short stature is the most likely most likely question for you this time, the main question. Okay, so you should be knowing that. So, and the last is, if it is endocrine, growth hormone deficiency, what you get? Growth hormone. Okay, genetic causes like Turner syndrome, also you can try growth, nutrition and also growth hormone. Clear? So now you write at least growth hormone you can write even if you don't write anything else. Clear? So now you know how to write. Even if it's a long question, definition, classification, clinical features, investigations and treatment. So when you're writing a theory answer also, it's very important to classify, to put the boxes. So definition, put a box, write the definition clearly. If you classification, write the classification, use flow charts, and that should come. So that's how all your pages will get filled. Don't put it in one corner and keep it. Okay, investigation also, put the block, like I told you, first trial, second trial, third trial. Management also, write down the causes in one part, write down the one line of treatment. Clear? So this is how you're going to write a short stature case. So even in clinics, nothing apart from this will be asked. Clear? Any doubts with regards to short stature? So even if you get a short stature case, don't go and complain saying that, oh, this is not a case. This is a case. We have done this. We have done it in clinicals. It is done in anthropometry station. So any point, short stature should not be difficult for you. Okay? So the next topic which we are going to learn is about obesity. That can also be a short case. It can also come as your theory case. And so what measurement we are going to look at there? So there we are going to define. So the same 3 steps. So we are going to look at, is it obesity? Second is, what are the classification? How do we say what is the cause for obesity? And the third is how to manage it, or what are the things you are going to do. Okay. So first thing is definition. So there we said height less than 3rd percentile and -2 standard deviation. Here we are going to calculate something. What are we going to calculate? BMI. And BMI is a anthropometry OSCE station also. So you should be knowing how to calculate BMI. How to calculate BMI? Height, measure the height and then measure the weight. Okay. So you're going to say weight in kgs divided by height in meters square. Okay. Say for example, I said the child's weight is 90 kgs and height is 140. So what is this? So not 140, 130. So what is this BMI? Can you calculate? Height divided by weight. You need a calculator, then keep a calculator. So you have to multiply height in what? Meters or centimeters? Meters. No, so you convert it into meters. So weight in kgs divided by height in centimeter cube. Sorry, centimeter square.
Approximately.
Yeah?
33.
33. Okay. So then once you get the BMI, what are you going to do next? You are going to plot it on the BMI chart. Okay. Now there is a caveat here. Above 5 years and below 5 years again. Above 5 years you can use BMI chart. Below 5 years you are going to use the WHO chart only. And how do you define now obesity? So below 5 years you are going to define obesity. You are going to use which is the BMI parameter In below 5 years, weight for height or weight for length. Okay. So you have to remember, if I want to define somebody as obesity, I have to check, is the child below 5 years? Is the child above 5 years? Is the child above 5 years? Use BMI. If the child is below 5 years, use weight for height. Okay. So if the weight for height, when I plot him on the weight for height chart, so in a WHO chart, they would have given you the weight for height chart. So you go to weight for height chart, yeah, weight for length chart. And you can see here plus 2 standard deviation, plus 3 standard deviation. Suppose it's above plus 3 standard deviation, then it becomes obesity. If it's between plus 2 to plus 3, overweight. Is that clear? So this is how you are going to plot weight for height and define obesity in a less than 5 years. Now if it is more than 5 years, I have to use BMI chart. So if you see BMI chart, I calculate our BMI was, so the child says, say for example is 7 years. What was his BMI? 30. Okay. So 30 is very high. Correct? So suppose it's 7 years. How much is his BMI? 30. So it's really high. Comes somewhere here. Okay. So you plot that age and you see where is the BMI. And the BMI comes above. So you have two lines we have to use. One is the 23rd adult equivalent and one is the 27th adult equivalent. So how do you define obesity? If the BMI comes above the 27th adult equivalent, it is obesity. If it is between 23rd and 27th, it is called overweight. Okay, these are the two things you have to know. If it is above 23rd, it is overweight. If it's above 27th, obesity. So there is no doubt in definition. Okay, so next is how do you measure the weight, height and head circumference? Usually because of practicality problem, we don't give that as an OSCE station. But you may be asked how to measure height, how to measure weight, how to measure head circumference, how to mid-arm circumference definitely they will give you as an OSCE station. Head circumference will give you, but height and weight they may not give, but we cannot say. So you should be knowing how to measure weight, height, head circumference and length. I have given you the checklist. Okay, so those checklists are the points what we are going to mark you. If at all it's an observed station. So there is an observed station, there is a written station in OSCE. So in the observed station we are going to see how you are doing. So how are you going to measure height? We actually wanted to do it in the ward because with the patient, but there is no tall patients. All of them are below 5 years and I am cooperative. I just came from there. That's why I know is there. Yeah, height is measured by stadiometer. Weight is measured by digital weighing machine. Okay. Now you have height stadiometer. So what should be the steps? The child should be removing the footwear and he should go and stand on the wall. And main important is you have to remember 3 contact points. One is the occiput should be in contact, shoulder blade should be in contact, buttocks and the heels. And the patient should be standing with the in the heels in a V shape like this. And the side hand should be by the side. Okay, and you should have removed anything, cap or something you should do. And so most important, and the face should be looking straight. And what is important is Frankfurt plane. Where in the Frankfurt plane? What is Frankfurt plane? Line joining from the external. You see here, canthus towards the occiput. This line should be parallel to the ground. So you should be looking like this. This line should be parallel to the ground. So the baby should be looking in the Frankfurt plane. So first you should say remove the footwear, standing against the wall, and then the baby should be facing straight with the Frankfurt thing should be parallel to the ground. Okay, and his 3 points should be in contact: occiput, blade, buttock, and heels. Okay, and then you pull down this till it fits properly in the hair, and then it should be measured to the nearest 0.1 centimeters. Is that clear? So that's about your height. Length measurement is stadiometer. So you fix the head at one point, and then the feet is kept against the plank, and this is moved front and back, and then you measure to the nearest 0.1 centimeter. Somebody should be holding the knees. And the baby here also, there we said the line, baby should be looking forward and the Frankfurt plane should be in the Frankfurt plane parallel to the ground. Here you should be looking upwards so that the eyes are, the eye connecting this to this should be facing the ceiling. This much you should be knowing. In weighing, how do you look at the weighing? How to measure weight? So you have either pan or you have this. So the first step is you have to make sure that the pan is empty, okay, it is clean, and then you have to press the tear key. So tear key is to negate anything you have used. That means if you used a sheet here so that the baby doesn't get dirty, if you also press the tear key, it minus that weight. And then you press the 0 key so that it becomes 0. Once it's not moving, you place the baby. And once it places the baby, once the reading comes, the reading should be stabilized to the nearest 0.1 gram. You are going to measure the weight. So is that clear? So you should not have any doubts when you are measuring weight and height. Okay. How do you measure head circumference? So whatever I am telling fast because I have already given you the checklist. You just go through that before coming for the exam. Yes. So how are you going to measure the head circumference? Cross tape method. So make sure that you have measured the tape here and it should cross over here. You should not measure end to end. Okay? And you should measure like this. Take two fixed points and minus them. Okay? And it should be crossed over at the TDR here. Don't cross over at the back. Make sure the 2 points, that is the supraorbital ridge, and here it is occipital. These are the 2 points should be in contact. So don't forget occipital ridge, occipital ridges and supraorbital ridges and occipital protrusions. Okay. What is microcephaly? So head circumference less than minus 3 standard deviations. Everything else is 2 standard deviations. If you forget, just remember everything else is minus 2. So only one. That is head circumference. Microcephaly is less than minus 3 standard deviations. Okay, that's an OSCE question. That's why I am telling you. So they may ask OSCE child's height is head circumference is plotted on the appropriate growth chart. So when you plot on the growth chart, it's below minus 3. You are going to say microcephaly. Then they may ask you give few causes of microcephaly. That's you are going to write. What are the few causes of microcephaly? Or macrocephaly, more than plus 2 standard deviations more than the. So here minus 3 standard deviations, there it is more than plus 2 standard deviations. That is macrocephaly. Okay, and you should be knowing few causes of macrocephaly. This is your homework. So you find out few causes of microcephaly, find out few causes of. I am just finishing off whatever can be asked in the practice. These are anthropometry is a definite 2 marker out of your 10 marker of your OSCE. So you should be knowing everything about this. Okay. And last is mid-arm circumference. How do you measure mid-arm circumference? So you locate. When you are locating, you ask the patient to keep the hand like this, flexed. Okay, and then you measure the acromion and then to the occipital, and then you plot the midpoint. And then once you are measuring, you make the hand straight, and then you measure the mid-arm circumference. There also you can use cross tape method, and the mid-arm circumference normally is about 13.5. Okay, and when do you make it below 11.5? It is SAM. Yes, very good. So 11.5 to 12.5, moderate managed. Is that clear? So this much you should be knowing how to interpret. Okay. Then they can ask you, this is done between 1 to 5 years. What are the other age-independent anthropometric parameters? So you have age-independent anthropometric parameters. That means it doesn't depend upon the age. We are saying 1 to 5 years it's constant because fat is not here. So fat deposition is same. So that's why we use it as an age-independent parameter. Can you give any other age-independent parameter? Just now we finished that. BMI. Okay. So you have some things like Canavities index, Rouse index. All these are examples of age-independent parameters. So now I told you what questions can be asked with regards to mid-arm circumference also. Okay. So then apart from that, what else? So mid-arm circumference. That's something I wanted to tell apart from this. Last is, what is the rate of increase of your head circumference, length and height in the first 1 year of life? Forget about after 1 year. At least in the first 1 year, how will you remember? You are going to divide the first 1 year into 3 months. So you have to write it and by heart it. So they will ask you. So you write one column as head circumference, one column for length, one column for weight. 0 to 3 months, 3 to 6 months, 6 to 9 months, 9 to 12 months. Okay, so write in the weight column. The weight column you are going to write 30. This is the ultra short note 3 marker plus OSCE station. So you should be knowing like that. Okay, so weight first 3 months, 0 to 3, 3 to 6, 6 to 12, 9 to 12. Sorry, 6 to 9, 9 to 12. 30, 20, 15, 12. 30 grams per day in the first 3 months. Second 3 months, 20 grams per day. Third 3 months, 15. The last 3 months, 12. Okay, do you understand? I know it's too much, but it's okay. You need to know this. And then length, remember 3 to 1.5, 1.2. Okay, 3 centimeter per month in the first 3 months. Next 3 months, 2 centimeters. Next 3 months, 1.5. Next 3 months, 1.2. Okay, now let's see the last head circumference. 2 centimeters per month in the first 3 months. Then 1 centimeter. Then 0.5, 0.5. This is the ultra short note. Plus it's important. Suppose if they ask you the OSCE stationer's head circumference, they will ask you this. What's the rate of increase in head circumference in the first 1 year of life? What you will say? 2 centimeter? 1 centimeter. Yeah, then 1 centimeter, then 0.5. So just put the block, put this, you will get the full marks. Okay, so this is all about anthropometry. Is that clear? Any doubts with regards to anthropometry? Okay, just a few points on obesity you need to know, and then we'll start. We'll definitely answer to it. Tomorrow we will do about growth a little bit, into the theory part, and then development. And the development OSCE as well as development assessment. In case development assessment usually will not be asked in your exam for your paper cut, you should be knowing the milestones. You should be knowing how to assess. If you know, that is good. So we'll do the development and growth both. It's like a theory session tomorrow, but we'll get one child to see how to do the assessment. But no, all of you should know how to plot the growth chart. Is there any doubt still? Which chart to use? How to interpret the growth chart? Any doubts in any of the parameters? No, you should not have. Okay? Because if you don't answer anything, no problem. You should be able to answer growth, development, immunization, nutrition. These 4 things must. Okay? So I'm sure you will be able to do much more, but I'm saying minimum basic is these 4. If you don't answer this, then only the question arises. Otherwise, there is no problem. So the next is obesity. Now we know the definition. So below 5 years, what's the definition? For overweight and obesity. Weight for height is more than plus 2 to plus 3 standard deviation is overweight. Above plus 3 is obesity. Similarly, BMI. I'm making you repeat so that it goes and you may not read again. Above 27 adult equivalent. Okay? When you plot it on the BMI chart. Above 5 years, I will use BMI chart. And 23rd to 27th overweight. Clear? Okay. Now next we come to classification. Now we finish definition. Next is classification. In classification, what do we need to know? We want to know now. Here we found it a little different. Here you remember what is the cause. One cause would be more eating. So whenever you have more eating, so you're going to call it as exogenous obesity. Exogenous. There is no reason. The only reason is some problem with the food or the physical activity. So if somebody wants to become obese, either there's increase intake or decrease expenditure. Correct? These are the 2 reasons. So you're going to say the reason when you have more intake, decrease expenditure, you're going to become obese, and that obese is called exogenous. And it is 98%. That means only a few causes are going to be actually pathological obesity or more. So most of them are exogenous. The other causes endogenous. There we divide as proportionate, disproportionate, normal variance, acquired causes, intrauterine causes. Here we are going to divide them as exogenous and endogenous. Endogenous, some problem within is causing the obesity. Whereas here it is outside food or no activity. Expenditure, yes, that's the cause. 98% of the times. Now, what are some of the features? If I want to say this child is exogenous obesity, this child will have a normal growth. 3 parameters will tell me that this child is exogenous obesity. What is that? Growth. Growth will be normal. Okay. Development will be normal. And this puberty will be normal. So growth, development, puberty is normal. Then you put this child as. So if you have a tall and obese child, like for example in your exam, that person was admitted in the ward. That's why that case was kept, was obesity. I think the first 3 days it was kept, or all days it was kept. So that child, he was so tall and he was fat. So what does it mean? If growth is not affected, it's more likely to be exogenous obesity. Clear? Okay. Now in endogenous obesity, now let's look at some few causes. So you remember again 3 divisions there. Here also we might have 3 divisions. One is monogenic, means genetic problem. There's some genetic issue. Monogenic, that means it's a little more for you, but just to understand, there's something called leptin. The hypothalamus can be involved, right? So there is a leptin mutation. They can have a genetic problem. So there's a genetic cause. Just if you forget about leptin, also just say monogenic. Okay, monogenic. Okay. And you have, and what's the feature of that? Early onset, very early. That means birth itself is big. All through the infancy he was big, and he was always big. That's too early, too soon, and hyperphagia. One of the important features, even in the night when everybody is sleeping, goes and takes and eats. So that's hyperphagia is one of the important feature of monogenic obesity, and it's early onset and it's too soon. Okay. And the other thing is hypothalamic cause, because hypothalamus is also going to cause a problem in the appetite center, everything is there. So if hypothalamic problem, say for example you have a tumor in the hypothalamus, or because of some intracranial problem, trauma or radiation, something you did and the hypothalamus became problem, that child also becomes obese. That child also will have hyperphagia. Okay, so that's about it. And the last is your some of the syndromes. Here also we said there are some syndromes which are bad. Yes, so you are going to think of syndromes and endocrine causes. Simple, it's not difficult. Now endocrine already you know. What are the endocrine causes? Hypothyroidism. Same causes what you had there. Here you are going to say the same causes. Hypothyroidism, Cushing syndrome, pseudo hypoparathyroidism, and one more is growth hormone deficiency. That's all. Okay. I told you when you have a short and plump child, think of endocrine cause, and that's one of the examples is growth hormone deficiency. So what will happen to these people? The people who are having some hypothalamic, they will be short and fat. Okay, and they can have puberty problems, they can have development problems, they can have growth problems. Clear? And one more, 2 important syndromes you should remember. Syndromes, I didn't complete the syndromes. What are the syndromes? Now these are endocrine forms. Now we are coming to syndromes. So you have some syndrome. Yeah, so you remember about Bardet-Biedl syndrome, Bardet-Biedl syndrome, Alström syndrome, Beckwith-Peakman syndrome. At least remember 2-3 syndromes. If you don't remember, it's okay, no problem. Nobody will cause any problem. As far as you know who's exogenous, in exogenous there is normal growth, development and puberty, whereas you have Zellweger syndrome also, where the development is abnormal. So Zellweger, just remember a few syndromes. If you know, good, but I am not forcing you to read this. But if you know, it is good. So even Down syndrome also you can put. He is also obese. Down syndrome also. So there is Down syndrome, Bardet-Biedl syndrome, Alström syndrome, Zellweger syndrome, and Beckwith-Peakman syndrome or Soto syndrome. That at least you remember. But anyway, it's okay. But just remember these few features. Now, why I am telling you all that is you have to look for that in your examination. All of those features are there. Are they there in this patient? That's what you're going to see. Clear? So in endogenous obesity, it could be monogenic. Monogenic means genetic. Okay. What is the feature? Very early, and he's having hyperphagia. Then next problem, hypothalamus problems. So you have to ask about any history of intracranial radiation, tumor, vomiting, headache, all that. And then we are going to ask about endocrine features. So you know what to ask for hypothyroidism, what to ask for Cushing syndrome, what to ask for growth hormone, and what to ask. So you know that. And then we are going to ask another syndromes. That is your Bardet-Biedl specific. When you look at that child, you will know. Yeah, Prader-Willi syndrome and Zellweger syndrome. These are the 5 syndromes you should know along with Down syndrome. Okay, 5 syndromes you should remember in obesity. Okay, so the next question to ask is, now we know in history. Now we have to ask it. So in history you should definitely ask about, what should you ask in history? For exogenous, you are going to ask for nutritional history. Okay, what kind of food he is taking, junks he is taking, whether he is skipping any meals, he is fasting, he is feasting, all that is important. Physical activity charting. That means we want to know what kind of physical exercise he is doing, how much screen time he is taking. That is definitely required for obesity, exogenous obesity. And growth history you should take, puberty history you should take, and development history you should take. So they'll all be normal in that. Whereas here they will be abnormal. And specific features you are going to see. Now let's look at on examination. What am I going to see for head-to-toe examination? So they'll ask you, okay, in your obesity child, what did you look for in the examination? So there are some signs of insulin resistance which you should know as a complication, which suggests there's a risk for metabolic complications. Why are you so worried about obesity? Because it causes risk for metabolic problems, like for example, diabetes, hypertension, cardiovascular disease, heart attack, right? So, and also in a female, you could also have PCOD, yes, PCOD, and also you may think of cancers. Okay, this much: diabetes, hypertension, cancer, PCOD, and liver disease also. Non-alcoholic fatty liver disease. That's a major killer nowadays. Non-alcoholic fatty liver disease. Clear? So what you're going to look for in the examination. Go for exogenous first, and then we'll come to syndromes. Okay. In exogenous, what are you going to see?
Darkening.
Yeah. So the most important is what is this? Thick velvety hyperpigmented patch over the rough. Yeah, acanthosis nigricans. Whatever. So acanthosis nigricans. Okay, that's an important feature. Second thing you're going to see, yes, acropodols, skin tags. Okay, skin tags you're going to see. And xanthelasma. Xanthelasma is plaque-like fat structures which are there. Xanthelasma. And then you're going to also see in an obese child, if you're going to think of complications, what else you're going to see? Abdominal obesity. So very important to measure the waist circumference. So waist hip ratio. Somebody who is 70th centile, you don't need to remember the centiles, but just remember additional measurement for metabolic risk. What you want to measure, they'll ask. So what you're going to say? I'm going to look at the waist hip ratio. Somebody is more than 90 centile, definitely has a complication. Somebody is more than 70 centile, is a risk for complication. So waist hip ratio, we're going to look for waist hip ratio. Remember that. Okay. The other features are pseudogynecomastia. You can have even, there's no palpable gland, it's only fat. It looks like pseudogynecomastia. So acanthosis nigricans, pseudogynecomastia, waist hip circumference, and one more point is hypertension. So look for complications, hypertension. This much you should know as a general part for any child with exogenous obesity. For endogenous obesity, few extra features you should be knowing. Like for example, in Bardet-Biedl and Alstrom, you will have retinitis pigmentosa. You can have retinitis pigmentosa on the eyes. Okay. In pseudohypoparathyroidism, Turner syndrome, you will get short fourth metacarpal. Metacarpal will be short fourth metacarpal. Bardet-Biedl and this one also, you have short, broad hands, very short hands and broad hands. Polydactyly. Polydactyly will be there. Okay. Just few features. If you know, it's good. If you don't know, no problem. But just remember what on examination in an obese child, what should I be looking for? If it is genetic causes, I'm just looking at an early onset and fat baby with a bit of development delay, with the development of puberty problem. Same thing, development delay, hypotonia, and few features will be there in Prader-Willi and Zellweger syndrome. Okay, so if it's genetic anything, growth is abnormal, development is abnormal, puberty is also abnormal, and when I look at the child, you have hypotonia in Zellweger's and Prader-Willi. Okay, whereas in Bardet-Biedl, I told you just look at retinitis pigmentosa. Look at short, broad hands and polydactyly. Even if you don't know that, definitely you should know hypothyroidism, you should know Cushing syndrome and growth hormone deficiency. What are the features you are going to look for in hypothyroidism? Okay, so lethargy, will be dull to look, hoarseness of voice, dry skin, mental retardation, coarse skin and constipation history. But sometimes in older child you may have some umbilical hernia also. But definitely dry skin, bradycardia and delayed ankle jerk. This much you should be knowing. Delayed relaxation of ankle jerk. This is for hypothyroidism. Cushing syndrome, moon phases, buffalo hum, striatum, hypertension. Clear? This much is for Cushing syndrome. Growth hormone deficiency, doll-like faces, mid-facial problems, midline defects and micropenis. This is what you are going to look for growth hormone. So I have told you everything of obesity. Okay? So next is, now same thing, there we did some investigations. Here what investigations we are going to do?
BMI.
For complications. Yeah, so measurement is BMI. We are going to plot the child and we are going to classify the child. And then we are going to also do screening for metabolic disorders. Like what is the screening you want to do? FPS. Right? You said risk for so many diseases. So we are going to just do the screening for those diseases. So you are going to definitely do, because these things were asked and we were not able to answer, and that it was not supposed to be not answered. It's just thinking. Just think. what should be asked? For this anybody, nobody will fail, but it's good to know. No, everybody knows obesity is a big disease which is coming. So everybody is better to know. So you're going to do FBS. So FBS more than what will you tell is significant? More than 126. So this is a OSCE station question because diabetes, see whatever is your certifiable skill can be kept for your OSCE. So just remember like that roughly. So just go through this, there are 23 certifiable skills, all of them can be kept as an OSCE. So they will give you a measurement of urine test, they will give you a measurement of FBS, then they'll ask you what is the diagnosis. So FBS more than 126. Okay. Post-prandial, post-sugar more than 200. Just remember 200. Okay. And then HbA1c 6.6. Clear? This much is important. That's for your diabetes. Next, this is also for your theory. That's why I'm just telling you now only what you're going to tell. After that, you're going to do screening for hyperlipidemia. Okay, you're going to look for cholesterol. You want to look at the total cholesterol, you want to look at HDL, you want to look at LDL. So remember that total cholesterol 200. HDL less than 40. Good, more HDL is good, less HDL is bad, less than 40. And then triglycerides, you can see 130. 130. Triglycerides and LDL more than 130 abnormal. Total cholesterol more than 200. Clear? These are risks for heart disease and hyperlipidemia. So that's why you should know about that. Okay. Finally, you should know, it is good to know the cutoffs for hypertension, but if you don't know, also no problem. But just remember, somebody who is coming to you to more than 90th centile is abnormal. Just remember that. Okay. Our 95th centile is little more. Okay. Less than 13 years, more than 13 years, more than 13 years, like for adults only. We say it's more than 130/85 is pre-hypertension. More than 140/90 is hypertension. So that is your cutoff for. You use less than 13 years, you use centile charts. Below 5th centile is hypotension. Okay. Whereas above 90th centile is 90th to 95th is pre-hypertension. Above 95th centile is hypertension, definitely. So whether with endocrine damage, without endocrine damage, that's why you put stage 1, stage 2. At least this much you remember. That just say hypertension also is one of the complications. Okay, so you have to screen for that. And then AST level you will do more than 40. AST more than 40 is abnormal. AST for non-alcoholic fatty liver disease. Okay, so these are the investigations you are going to do. If it is specific for endocrine, you are going to say thyroid profile. If it is for the genetic studies, you are going to say mutation analysis, or you are going to do whole exome sequencing. So you are going to say genetics test studies for syndromes. Syndromes you say genetic studies. You say methylation study, that also is okay. Or whole exome sequencing you say. And thyroid endocrine problems, do the specific hormone. Okay. And risk of complications. Last is the management. What will be your management? So exogenous is diet and exercise. Okay. So there is something called 5-2-1-0 rule. Okay. 5 means 5 servings of fruits and vegetables. Plenty of fruits and vegetables. At least 5 servings you should have fruits and vegetables. 2 means less than 2 hours of screen time. 1 means at least 1 hour of moderate to severe physical exercise. That means you should not be just sitting and walking. Walking slowly is not an exercise. Moderate, at least brisk walking, 45 to 1 hour. 45 minutes to 1 hour. That's your 1. And 0 is 0 beverages and junk foods. Okay, so this is your 5-2-1-0 rule. So that sums up the management. Drugs for you in undergraduate, they will not ask. But if you want to know, there is something called as orlistat, there is something called as peptide. So we are metformin for somebody who is having diabetes and fatty alcohol liver disease, you can use metformin. Okay, that's about 10 years only, not recommended below 10 years. Is that clear? So there are some drugs. That's for your nice to know and you want to get distinction marks, you can write those. Because it's both theory and practicals. Practicals there will be short cases kept because of scarcity. That's why these are all coming as short cases. Otherwise, usually we don't keep. If the normal cases are there, we don't keep. But still, today you are normal. Even if obesity case comes, you know now what to take, right? So you want to know how to classify. You know what to measure and what complications to look for, what investigations to do, and what management. You just write 5-2-1-0. That's all, and just expand that a little bit more. And then it says drugs only in specific indications. That's all. So this completes short stature and obesity. So 2 cases we finished, and I also told about how to measure the angle. So OSCE stations which can come is measurement of height, measurement of weight, interpretation on the growth chart, how to classify and how to BMI interpretation, mid-arm circumference, how to measure, how to interpret, head circumference, how to measure, how to interpret. Clear? So now you know all the OSCE stations. Okay? So only one more thing which can be asked is growth velocity. That also I have told you. What can be the growth velocity? 2 measurement points they will give you, and they'll ask you to calculate them, and they'll have a growth velocity chart also. The last part is what is growth chart? What is growth chart? Suppose you get a question like last time they got a question on growth chart. What will you write? So you are going to say it is the best measurement of growth. It is for evaluation of the growth, right? For evaluation of the growth, what we do? We are going to go for over a period of time. So 1 point measurement cannot give you a reflection of the actual growth. So it's always better to measure the growth over a period of time and plot it on the chart, which will give you to see how the child is growing and whether he is normal for the population. That's why, so that I can identify where is the problem, how much is the problem, and start intervening early. So that's your aim of growth chart. It's a road to health chart. The word road to health itself, if you write, 1 mark will be given. That's about the preamble. So any answer you're going to write like a preamble, an introduction, and then you're going to write types of growth chart. So what are the types of growth chart? They're growth reference and growth standard. That's maybe a little difficult for you, but just remember you're going to say 2 types of charts are there. There are growth reference and growth standard. Okay, and I'll give you some examples of it also. So now if I look at the IAP chart, are examples of growth reference. Whereas the growth standards are your WHO chart. What does growth standard say? They are telling this is how the child should be growing. Whereas growth reference chart is how the child are actually growing. So what did IAP do? He grouped up all the people at one stage. He measured the height and he plotted them on the growth and made a growth chart. That becomes growth reference. But growth reference is more like what is actually happening. What happened in WHO growth chart? They got some preconditions that all these children should be exclusively breastfed, okay, and their mother should not be smoking. And then when they were born, I just plotted them all till 5 years and then made the growth chart. And that is by 5 countries. You know which are the 5 countries? WHO growth chart. India is one of them. So BONGUI, Bongui you can remember. B is for Brazil, O is Oman, N is Norway, okay, G is Ghana, U is USA, and I is India. Okay, so all these group of from these different countries. That's why it's a multi-center. So it's called multi-center growth chart, right? So multi-center MGRS chart it is called. So what does it say? It's a gold standard. It's how the child should be actually growing. Whereas growth references how actually the child is growing. Example there is WHO. Here it is IAP. How the WHO charts were created? It had some preconditioning. All of them breastfed and no smoking. And then I plotted all of them up to 5 years and then I created the chart. But that's like an ideal chart. It should be like that. But what is actually happening is
reference.
And then we change. Below 5 years, WHO. This is above. This is
IAP.
Above 5 years, IAP chart. At least this much you can write up for growth chart. So you can tell the definition, you can tell what is it, what are the different types of growth charts you have now. One is growth reference, growth standard, and also you can say for different measures. So there is a height chart, there is a weight chart, there is a head circumference chart, there is a weight for height chart, there is growth velocity chart. Similarly, you have some charts for specific syndromes like Down syndrome, there is different. IUGR babies, there is a different. So there are different charts for different. That's a little too much for you, but at least remember this. Just this one paragraph will guide. That much you remember. Okay. Whereas in growth reference chart, the other type of chart is percentile chart and Z-score. Okay. So when I say percentile chart, what does it mean? Means that I have measured 100 children in ascending order, and I have just plotted them from 1 to 100. And I have given the percentiles. That means we know that so many children are above, so many children are below. And then I put them as they follow the Gaussian curve, right? So within 2 standard deviation, 95% of them are actually coming. What happened? LDM. No, which patient, which batch you are? 6th term. You come in the morning and discuss. Morning 9:15. Okay, so that's another type. Percentile at Z. Percentile is what? No, I'm just telling you all this because this came as a exam question. So you should know what to write. So percentile charts are created by putting all of them in ascending order and then plotting them where you stand from the median. So the median is average of all of them. And compared to the median, how far from the median he is? Is he so much or is he less?
Yes.
So ideally he should be between 3rd and 97%. Okay? Whereas Z score is what? What do you mean by Z score? So you say no. So there also you are going to see, you are creating the standard deviation. How far he is from the median again. Whether it is +1, +2 or +3 or -1, -2 and -3. Okay. So if his -3 standard deviation is equal to first percentile. -2 standard deviation is equal to 3rd percentile. Just remember this much. Okay. Now why do we want this percentile chart? Why do we want this Z-score chart? Percentile means I can compare individuals on a similar parameter. That means if I want to compare height, only height I can measure of a particular person, and I can measure that this person is shorter than this person or this person is longer than this person. But if I want to compare 2 or more components of different measurements, suppose I want to compare a weight child and I want to compare a height of the child, then what parameter I should use? Z-score chart, or I have to use standard deviation chart. Is it clear? What does Z-score tell? It includes standard deviation, how far from the median is he? And if he is within 2 standard deviations, what does it mean? 95% of the population is within 2 standard deviations. That's why it's considered as normal. Somebody who is below -2 standard deviation, abnormal. Somebody who is below -3, more abnormal. So that's why your SAM definition. What does SAM say? What's the SAM defining criteria? Weight for height less than -3 standard deviation. 3 criteria are there. Less than, that's also an OSCE station. We'll again come back when we're discussing SAM, but at least remember for today, weight for height less than -3. Then 11.5 mid-arm circumference by PP fitting edema. These 3 criteria will put us SAM. Why I told you today is, this is how you're using the data to classify them. So if I want to know if I want to compare 2 parameters like weight and height together, then I need 2 different measurements. No, one is in centimeter, one is in weight. So if I categorize them and tell that his weight is below -3 standard deviations and height is below -2 standard deviations, I can give you a similarity. But same thing I cannot compare it in the percentile chart. Percentile chart, same variables can be compared, whereas various variables can be compared in a Z-score chart. At least basics, I'm just making it very simple. Z-score chart, that is the reason. And you're going to use it below 5 years. And the reason is you can compare different measurements in a single chart. Okay, based on how far is from the median. Is he +1, +2, +3 for higher, -1, -3 or -2 or -. So who's abnormal? Suppose he is below -3, you're going to say weight for height below -3, you're going to say severe
acute malnutrition.
If it's between -2 to -3,
Moderate.
Moderate acute. All this we will be discussing again in your SAM. But at least today, because growth charts can be a part of this. So today just go through what is given and make an answer for growth chart. And sometimes, very rarely, they can ask you about Z-score, but it's not required. But if you can read, Guy has given it very well. Just read something about Z-score. That completes in growth chart. Suppose you write everything about growth chart. I have given you an outline structure. What is growth chart? What are the types of growth chart? What are the advantages of each? Okay, so this much you read. So today you go home and just, so in your plan, as I give, I already told you, today will be growth, tomorrow will be development, next we can discuss about nutrition, immunization, like that every day we'll be discussing a few things. So that day you just go and read, the must-knows. Must-knows should be read repeatedly. You should read it more and preferably make a mind map. Like in one page, you write out all the problems. Now, don't you think how many pages it took for short stature? It took very less. So you just write down those points in a single paper and keep repeating it. Then you will never forget it. Not never forget it. Chances of remembering is more and writing down is better. But if you just read